Good afternoon. I'll be talking on basics of electrophysiology. Direct quantitative objective assessment of the visual pathway at different levels. ERG is at the level of the retina, VP at the level of visual cortex, and EOG at the level of RPE. Full field electroretinogram is a mass electrophysiological response to diffuse flashes of light, and it used to assess generalized retinal function. ICEF has standardized the full field ERG into total of 6 responses. The first 4 are the dark responses, and the last 2 are the light responses. The 3 electrodes are active electrode is placed at the cornea, reference at the outer canthus, and ground electrode is placed at the forehead. Pupil is dilated. There is 20 minutes of dark adaptation for recording the scotopic responses and 10 minutes of light adaptation for recording the photopic responses. Dark adapted 0.01 is a single flash rod response. It's a pure rod response. There's a slow positive B wave only. Reduced amplitude or prolonged implicit time is seen in conditions affecting the rods like RP and CSNB. Dark adapted 3 ERG is a combined rod and cone response. A wave is from the photoreceptors and B wave is from rod and cone bipolar and Muller cells. Dark adapted 10 ERG is also a combined response to stronger flash, and it is more informative in patients with opaque media, small pupils, or immature retina. B waves are the ones that arise largely from rod-driven on-bipolar cells. Dark adapted 3 oscillatory potentials are low amplitude wavelets superimposed on B wave. Primary contributor is amacrine cells. It's sensitive to effects of ischemia and decreased in ischemic disorders like DR and CRVO. Photopic ERG, the first response is light adapted 3 cone response. In this, A wave reflects the function of cone photoreceptors and off bipolar cells, and B wave reflects from on and off cone bipolar cells. Light adapted 30 Hz flicker is recorded to repeated standard flashes at frequency of 30 Hz. It's more sensitive measure of cone system dysfunction and generated by cone on and off bipolar cells. Amplitude is from trough to peak of each response, and peak time is around 24 to 27 milliseconds. Latency is the interval to the commencement of A wave after the stimulus is applied, and implicit time is the interval from the stimulus to the peak. B wave amplitude is measured from the A wave trough to the B wave peak. Indications of ERG are photoreceptor dysfunctions like in retinitis pigmentosa, inner retinal dysfunctions as in CSNB, inner retinal dysfunction with vascular etiology like in CRAO, and drug toxicity like in HCQS. Diseases affecting photoreceptors produce abnormal A and B waves. Disease that affects only the bipolar cells leaves the A wave intact, which is the electrode negative ERG seen in CSNB. Completely extinguished ERGs are seen in Leber's congenital amaurosis and severe RP. This is a printout of full field ERG, the normal ERG, where the first 4 responses are dark adapted and the last 2 are light adapted. Pattern ERG is localized retinal response evoked by contrast reversing pattern. No dilation of pupils to maximize the retinal image quality. It's dominated by the response of RGCs driven cone photoreceptors. The waveform includes an initial negative N95 followed by a larger positive P50, which is followed by a larger negative N95 component. It differentiates between macular and optic nerve disorders. In macular disorders, P50 is abnormal, and in ganglion cell disorders, N95 is abnormal. This is a printout of a normal pattern ERG with normal P50 and N95 amplitudes. Multifocal ERG are cone-driven bipolar cell activity. It provides insight into macular pathology. Patients must maintain accurate fixation, so pupil dilation is not required. Multifocal ERG assesses many local ERG responses, 61 or 103 hexagons within the central 40 to 50 degrees. There is an initial negative deflection N1 followed by a positive P1 and followed by a negative deflection N2. MFERG is used in diagnosing retinitis pigmentosa with central involvement, Stargardt's disease, HCQS toxicity, and BRAO. EOG records the standard potential between front and back of the eye, which depends on integrity of RPE. The ratio of highest amplitude recorded in light adaptation to lowest amplitude recorded in dark adaptation is given by Arden's ratio. More than 1.8 is normal and less than 1.65 is abnormal. EOG abnormalities are proportional to severity of rod-mediated ERG abnormalities and are not of diagnostic importance, but the exception is best vitelliform macular dystrophy, in which full field ERGs are normal and EOG is abnormal. Visually evoked potential electrophysiological responses to pattern of flash stimuli recorded over the occiput. It's valuable in diagnosis of optic nerve disease and is a method for assessing function of visual pathway from retina to the primary visual cortex. Recording the VEP requires a natural pupil size. Records are best taken at a fixed distance. The non-stimulant eye should be included. Pattern VP has a first negative waveform which is N95, first positive which is P100 and second negative which is N135. The main measurements are the amplitude and the latency of P100. This is a normal pattern VP printout in which the P100 amplitude is normal and there is no P100 latency. The optic nerve demyelinating diseases like optic neuritis and multiple sclerosis, in this there is VP peak time delay. And in optic neurodegenerative diseases like an optic nerve atrophy and ischemic optic neuropathy, there is a decrease in amplitude. Flash VP is a crude approach. It indicates that light has been perceived. It is unaffected by opacities in lens and cornea. It is useful where there is limited cooperation, and it is done when pattern VPs are not recordable. This is a printout of a normal flash VP. It shows N2P2 amplitude, which is normal, and there is no latency. How to select visual electrophysiology examinations. Optic nerve disease, you should check pattern VEP. Where pattern VEP is not possible, you can do a flash VEP. Eye trauma, you have to check for VEP, pattern and flash. Hereditary retinopathy, full field and pattern ERG or multifocal ERG. Vascular retinopathy, full field and multifocal ERG. Macular diseases, multifocal ERG and pattern ERG. Toxic retinopathy, full field and multifocal ERG. Glaucoma, pattern ERG, and unexplained visual loss, check pattern VEP or flash VEP where pattern is not possible. So there are two cases. The first one is a case of retinitis pigmentosa. When we went ahead and did the ERG, there are completely extinguished waveforms in the first 4 dark adapted and also in the light adapted. The second case was a 24-year-old male. The visual acuity was 6.6, but the autofluorescence showed us that it was a case of Stargardt's disease. We went ahead and did multifocal ERG. There was diminution of central amplitudes in both the eyes. And the full field ERG, the rod adapted, the dark adapted, and the light adapted was absolutely normal. Thank you.
Thank you. Very good presentation. I think you have summarized everything, the ERG and VER as such. Tell me the few condition which you would like to do, one or two.
Basically, we would like to do.
You are in a medical college?
No, I'm in the Shofai Center.
Private there.
Private,
The
yeah.
ERG, VR is there.
You
tell me the
hereditary retinal degeneration.
Okay, that is the one condition.
So retinitis pigmentosa and also in Stargardt's disease.
Stargardt disease. Good.
But before doing the ERG, should mention what dark adaptation, visual fields. These are more important than ERG.
Yes.
Number 2.
Yes.
This DEP is meant for the cortical blindness also.
Yes.
So, not only the optic, the
Yes.
should always do this in the cortical also, huh?
Yes, ma'am.
Thank you, Dr. Stuti.
Welcome.